According to current medical literature, up to 70% of individuals with autism spectrum disorder also carry a comorbid diagnosis of ADHD. For decades, the DSM-4 made these two diagnoses mutually exclusive, but when the DSM-5 was published, it explicitly allowed clinicians to diagnose both conditions in the same patient at the same time. The data supporting this change comes from meta-analyses, but looking closely at the individual studies reveals that the reported comorbidity rates fluctuate wildly, landing anywhere from 10 to 90%. That massive variance points to a methodological flaw rather than an established biological reality. By uncritically accepting that these conditions frequently overlap, clinicians risk pathologizing traits that are intrinsic to autism, mislabeling them as a completely separate secondary disorder. Treating the physical agitation and inattention of an autistic patient as standard ADHD obscures the distinct neurobiology actually driving their behavior. Diagnostic confusion happens because both clinical profiles share surface behaviors, like inattention and physical agitation. In ADHD, this pairs with being talkative and eager to interact. Autistic children, however, exhibit repetitive motor functions, their agitation caused by sensory overload. Because initial diagnostic tools rely heavily on observing broad external behaviors, we frequently mistake two different biological causes for a single additive comorbid condition. Standard executive function evaluations are often used to justify dual diagnoses, but they routinely fail to accurately discriminate between the two conditions. Research by Carter, Leno, and colleagues tested this directly. They found that multiple executive functioning impairments, typically associated with ADHD, are routinely present in youth who only have isolated ASD. This chart represents data from a cognitive switch task, measuring cognitive flexibility and reaction time variability across neurotypical, ADHD, and autistic groups. When controlled for symptoms of oppositional defiant disorder and ADHD, differences in reaction time between groups became statistically insignificant. Cognitive flexibility aligned across the board. The ASD group alone exhibited impaired response inhibition and premature responsiveness for structural reasons entirely separate from an ADHD profile. Furthermore, higher functioning patients on the spectrum possess a highly specific attentional impairment profile, not observed in patients with more severe ASD or isolated ADHD. Relying on standard executive function outputs creates inevitable false positives for ADHD in the autistic population. To understand what is actually happening, we have to precisely define what attention means in the context of autism. Attention is a complex psychological construct made up of discrete subcomponents. It includes sustained attention, visual search, and orienting toward new inputs. Comparing sustained attention duration, ASD patients possess objectively superior focused attention compared to ADHD and neurotypical baselines. On cognitive evaluations like visual search tasks, individuals with ASD perform better, exhibiting a highly focused trait, clinically recognized as hyperfocus. This hyperfocus stands in direct contrast to true autistic attentional impairments, a severe difficulty in disengaging, shifting focus, and orienting toward new non-social stimuli. Rather than a short attention span, autistic individuals lack joint attention, the shared focus of two individuals on an object. This early deficit acts as a primary driver of later social and communication difficulties. What presents clinically as inattention in autism is actually a complex combination of local detail hyperfocus, context blindness, and sensory overreactivity. ADHD etiology is rooted in a prefrontal cortex inhibitory control deficit. In contrast, ASD prioritizes sensory processing and emotional modulation. The amygdala generates top-down signals, creating emotional attention that overwhelms perceptual inputs, while cerebellar hypoplasia correlates with delayed reflexive attention. EEG and event-related potential studies demonstrate that while both disorders show atypical attention allocation, their foundational brainwaves and structural impairments follow distinct, non-overlapping profiles. The neurobiological reality of these disorders reveals two divergent information processing pipelines. A blanket dual diagnosis is neurologically unsound. True neurobiological comorbidity of ASD and ADHD does exist in a much smaller subset of patients, but its presentation diverges from the inflated 70% figure. We see this in fMRI data from Chanteloup and colleagues, comparing youth with pure ASD, pure ADHD, and actual dual diagnoses during temporal discounting tasks. These comorbid patients exhibit severe structural impairments in specific brain regions that remain unaffected in subjects with a single diagnosis. True comorbidity involves severe impairments in the ventral striatum, the anterior cingulate cortex, and the ventromedial prefrontal cortex. Genuine comorbidity is a distinct neurofunctional entity that requires specialized study. It is not a casual overlap of two common childhood disorders. This misclassification has severe, real-world clinical consequences. Treating an autistic patient for a phantom prefrontal inhibitory deficit can lead to dangerous pharmacological outcomes. Amphetamine-based treatments intended to manage ADHD frequently trigger paradoxical, highly undesirable effects in the ASD population. This occurs because ASD is biologically linked to dopaminergic hyperactivity along the brain's nigrostriatal and mesolimbic pathways. This excess dopamine naturally accounts for both stereotypic motor restlessness and interpersonal deficits. It is a biological mechanism that directly opposes the dopamine deficit model of ADHD. Blindly applying a dual diagnosis based solely on surface behaviors risks subjecting autistic patients to chemically counterproductive and physically harmful interventions. Current psychiatric nosography must evolve. We can no longer rely on simplistic symptom checklists that conflate entirely different biological diseases. It is necessary to explicitly include sensory-driven attentional dysregulation and motor restlessness as core intrinsic diagnostic criteria of autism spectrum disorder itself. Traits like hyperfocus, context blindness, and delayed reflexive orienting are foundational hallmarks of autism. They are not a secondary pathology to be outsourced to an ADHD diagnosis. Respecting the true neurobiology of autism means discarding the comorbidity illusion. Only then can clinicians treat the complex architectural reality of the spectrum on its own terms.